Hey everyone, welcome to this edition of the CHP Spotlight interview series. Today is a really special one. We are joined by Dr. Brent Wiesel from Medstar. Dr. Wiesel is an orthopedic surgeon specializing with the shoulder and the elbow. Both adolescents and adults are who he treats. And also, which I didn't know, he's the chief of shoulder service at Medstar Orthopaedic Institute. So first off, Dr. Wiesel, thank you so much for joining us.
Sure, thanks for having me.
Awesome. So for those of us out here, could you, or watching this, could you tell us a little bit about what you do, the types of conditions that you treat and patients that you typically help?
Sure. So I am a shoulder surgeon at Medstar Georgetown University Hospital. Been there for about 15 years, and I take care of about 98% shoulder at this point. The cool thing about shoulder is my practice sort of varies from adolescents all the way up until people in their 90s. Sort of treat the full spectrum of shoulder injuries. In the adolescents, it tends to be a lot of shoulder dislocations and instability. Then you get into the middle age group, a lot of rotator cuff problems, and then our older patients, I do a lot of shoulder replacements, take care of a lot of proximal humerus fractures after falls and that sort of thing.
That's really cool. And are you seeing, like, when you mentioned obviously the different populations you see, and the majority of people who a lot of times we work with fall into kind of two buckets. It's the adult athlete and the youth athlete, right? So for, I guess, starting off with like the more adult athlete, somebody in 40s, 50s, wanting to like, just work out in the gym or be able to play tennis or golf or whatever the case may be. Are there any common sort of call it like mechanisms of injury or like or things that maybe have resulted in some of the issues, whether it be traumatic stuff, overuse, something, anything like that?
Sure. I mean, Washington's a highly compulsive town, so those middle-aged adult athletes are the vast majority of what I see as well. And by far the most common problem they have is rotator cuff problems, whether it's just degeneration or inflammation of the rotator cuff all the way up and through full thickness rotator cuff tears. Most of the time that tends to be an overuse sort of injury. It'll come on slowly with time, probably partially because of their high activity levels. Occasionally it'll be a traumatic injury, or sometimes it'll be kind of a tendon that was already at risk because it was degenerated because of all the overuse, and then there'll be a single traumatic injury where they suffer a tear.
Got it. So it's kind of like almost like a straw that broke the camel's back sort of situation.
Exactly.
Got it. No, that makes sense. And then for, is there anything, and it's always find this question interesting. Is there anything like, man, if I wish like more like adults or people in general just knew about doing this or could take care of themselves in this way, maybe, again, you never guess really could fully prevent anything, but maybe to reduce or mitigate risk in some ways from what types of things you see. Is there anything that comes to your mind in that regard?
Yeah, I mean, I would think sort of one activity to avoid and one activity to do. I can think of, in terms of the activity to avoid, you really got to be careful, especially as you start getting 30s and beyond, of doing weightlifting where you're pushing weight away from your body overhead. That puts a lot of stress on the shoulder. So everybody comes in, if I could get rid of one exercise in the world, my knee surgeons hate the leg extension, or my knee surgeon partners hate the leg extension machine that everybody wants to do. And as a shoulder surgeon, the one that kills you is the military press. Everybody comes in and thinks, I want to strengthen my shoulders, I got to do military press. And most of the time, the problem with the shoulder is not the bigger muscles around it being weak, because we're all good at strengthening our bigger muscles. It's the rotator cuff muscles that need to be balanced with the bigger muscles and keep that shoulder biomechanically correct that are weak. And so that exercise actually stresses the shoulder instead of strengthening it. So I think, it's certainly overhead lifting can be done, but you really got to be careful with the technique that you're using, and sometimes the juice is not worth the squeeze. So you can get a lot of the same muscles. You can get your deltoids by doing lateral raises. You can get your traps by doing shrugs, and and so exercises where you're pulling down towards you are actually great. So lat pulls and pull-ups are great exercises for the shoulder, but that pushing weight away from you is not so good. So that's one I'd like to see people avoid. If you ask me the one thing I'd love to see everybody do, and this is a little less realistic, but especially people that have had shoulder problems, is rotator cuff strengthening exercises, using TheraBands just for internal and external rotation with the arm at the side are the key. I really think that's the key to shoulder health. It's sort of like brushing your teeth for your shoulder, and everybody ought to be doing them. Certainly, if you had any shoulder problems, that's your sign that you got to do them for both sides really forever. And maybe not the same way you do them when you're recovering from an injury, where hopefully you're doing them 5-7 times a week, but just 2 or 3 times a week. If you look at my office, all my partners have doors down for me, and everybody's got a TheraBand on their office because at some point or another, they've all had shoulder problems, and that's the first thing I get them doing. And so I think if you can do that as a warm up for whatever else you're going to do, it really goes a long way to keeping you from needing my services.
Sure. Yeah, that's really great advice. I appreciate that. And that's yeah, it's funny. It's not like, it's not sexy to do, the small little mini band exercises and more rehabilitative stuff. It's a lot more, fun, and probably looks good on Instagram to do a lot of the big bang drills and stuff like that. But for sure with you there. And then it's interesting what you say about like the military overhead press, right? That's a really good suggestion. A lot of times what we see, I know on the rehab side, is that we work with a lot of people who do that a lot, like CrossFitters or folks like that. And very rarely on a table does anybody, like when you take, the bar out of their hands and see just on an isolated fashion, do they have the prerequisite, overhead motion to actually get there? Very rarely do people actually have the ability to get into those positions in a non-compensatory kind of way. And what's interesting then is all of a sudden you're like, okay, on a table, we don't quite have that motion, but then we want to load it up, and it's just, you're right, there's not a lot of room for error there. And then under load, obviously, your technique's not going to be perfect every single time if you're pushing it. So totally in agreement with you there. And then sort of similar question for more of like the high school athletes. I know you see a lot of those folks. By the way, for anybody watching, I found out something interesting doing a little research. Was Dr. Wiesel, I had no idea that you were so big in the rowing world from back in, I believe, the 90s, right? You were on was it Olympic team? Is that right?
Yes, it was whitewater slalom kayaking.
Kayaking, there we go.
A little different from rowing. But yeah, that was a long time ago. But yes, so I was on the national team training for the 96 Olympics, and then hurt my shoulder going into the summer of 95, sort of tried to limp along and make it through and couldn't. So I had 2 shoulder surgeries on mine fall of 95 and in the spring of 96. Enough to come back and be able to keep kayaking and do some first ascents and that sort of thing, but not sort of meet the demands you need to compete at an Olympic level. And so I ended up stopping, going to med school, and go on from there. But with the youth kids or with younger patients, the issue is almost always instability. That's the problem that patients get. And I'd love to tell you that we had a great way to prevent that. But I think it really, a lot of it, the more and more we look at it, it's sort of the to some extent, the genetic makeup or the biomechanical makeup of the patient. And there's some people, that just have shoulders that are prone to dislocate, and some that don't. And then if, you take those people that are prone to dislocate and you put them in high risk activities, there's not a whole lot you can do, frankly, to stop them. At that point, it becomes somewhat a little bit of luck. And I think the first time I really thought about this is something Russ Warren, who was a orthopedic surgeon up in New York, who took care of the New York Giants for, 20 or 30 years, said. We were having this sort of similar discussion, and somebody said to him, well, Russ, what do you do with these guys in the NFL? And he's like, very rarely do you see an NFL player with a shoulder dislocation. And the reason for that is because these guys are such superb athletes. The guys that have the potential of dislocating their shoulder, they sort of drop out somewhere in high school or college because they just don't. They don't. There's something about their makeup that doesn't let it stay in there when it needs to. And so, for those kids, once they've once they've had problems, a lot of times we can get them back, but they certainly are at a higher risk than somebody that's never had them.
Gotcha. That's super interesting to hear. And it's a good point about the sort of natural selection process that happens with a lot of these athletes as they get to that sort of professional level. And it's interesting. I look at it a lot of times as like, you know, and all as you know, if you're gonna get hurt prior to that, right? It's like in any sport, like you said, you're gonna get weeded out, but also there's things that almost like, do they have the prerequisites to be playing the sport themselves? So a lot of times the people with they're more loosey-goosey and things like that. I feel like at times also end up gravitating towards sports that maybe where that's more advantageous. Of course, on the flip side, right, it can kind of beat up the shoulder, like in baseball and stuff like
Yep.
that. So that's really interesting. So when you have those athletes who do, you know, let's say they do dislocate or something like that, being a common sort of youth injury, that I know we've certainly seen a lot. What typically happens after the fact? So like if I was a high school kid, I dislocated my shoulder and I came in to see you, what might I expect?
Yeah, so this is where we've changed, I would say, in the last certainly no more than 10 years, and really in the last 5 years, the thinking on this has changed dramatically. So we used to say, you know, first time you dislocate your shoulder, we knew if you were under the age of 20, there's somewhere between an 80 and a 95% chance it's going to come out again. If you're over the age of 40, it's less than a 10%. So this really is, as I tell people, this is the one time being young in my office is bad. But so, you know, if you're in that underage, or if you're in that group under the age of 20, we used to still say, well, it's not a 100% chance that you're going to come out. We ought to put you in physical therapy. We ought to strengthen up the muscles that help hold the shoulder in place, and then we'll let you go back to your sport and see how you do. And that thinking has really evolved, I would say, tremendously over the last 5 years, because at this point, you know, most of the people that do this, I think, are trending towards at least offering, and if not recommending, really surgery for those first-time dislocators. Because the chance of you coming out really is somewhere between 80 and 95%. And, you know, you do get a slightly better repair on that tissue if you get it the first time they come out. You know, that tissue is really just sitting right there. You can go in there arthroscopically, you can sew it back up. And I think that's your best chance of, you know, giving them a stable shoulder that's very much, you know, like a, you know, with all this normal range of motion and everything else that they would have had. As opposed to, you know, if you wait till they come out a second time, then that tissue tends to be scarred into place. You have the damage from the second dislocation. Things are stretched out a little bit more. I think our results aren't quite as good. And we're sort of looking at it now much more as an inevitability than we used to. And so I think that it's not true for everybody, but, you know, certainly if you're young, you're active, and an athlete, you dislocate, there's much more of a role for surgical care the first time around now. And that's very different than it used to be.
Gotcha. That's really that's really interesting, and based on those numbers, I mean, totally makes sense. And
now I'll prerequisite, or not prerequisite, but I will say that it doesn't mean there's not a role for the rehab. I mean, I actually think it makes rehab more important, because I think what we do is, so we take them, we fix them that first time, and now you've sort of identified the patient at risk, right? So now you've got that shoulder plus the other side. They want to go back to their sport. It makes the work that you guys do that much more important, because, you know, you're able to identify them while they still got really a good fixable problem, as opposed to waiting until it's been out multiple times. And yeah, we'll fix them and we can tighten them up and everything else, but we're going to have to make some compromises in terms of making them tighter than we want to, or whatever we need to do to really to make them stable.
gotcha. No, that's really interesting. It's actually it's cool to hear you think about it in terms of like, oh, this helps identify the, you know, the higher risk people, because sometimes you don't know that until unfortunately something happens. And so I guess one of the, obviously naturally when we think of shoulders, and think of shoulder injuries, elbow injuries, things like that, one of the main populations that pops into your head are baseball players, right? So I'm curious, like, so for you, I'm assuming you see a good amount of those folks, and for them, you know, when they have some of the injuries like what we described, or if there's a lot more common ones like, you know, your UCLs or other shoulder stuff, or other UCL's elbow, but other shoulder stuff. I guess what what's a typical difference in treatment when you have somebody like that? Obviously, just knowing that there's certain things to be mindful of for a baseball player, such as, I know a lot of players we talk to, we see a ton of baseball guys at our place. I know their big concerns are like, okay, if we have to get a shoulder repaired or whatever way, is almost getting too tight
Yep.
and stuff like that. So what types of things do people need to be mindful of in those sort of situations?
Yeah, I mean, I think you touched on that a little bit earlier in the fact that, especially for the pitchers, but even for the outfielders and the shortstops, the ability to throw a baseball the way they throw it is not a natural thing, and so it takes a shoulder that's looser than normal to be able to do that. And so in those guys, the results of surgery in throwers is not great, because it's so hard to get them back to what they're trying to do. And it makes it that much more important, number one, to really have good therapists that they're working with, start all the way up from the core and the lower body, and the scapular stabilizers and everything else when they build them back up, to really try and avoid surgery. And number two, I think everybody recognizes it, but nobody knows how to fix the problem. Is you'd really like to see these kids not playing baseball 11 months of the year. I think this rash of UCL injuries you're seeing in pitchers this year, everybody says, "Oh, it's a pitch clock." In the medical community, it's not really a mystery. Sure, they're throwing harder. Sure, they're throwing at maximal effort, more frequently for shorter periods because of the use of relievers and everything else more. But it's they can change whatever they want on a Major League Baseball level. It's not going to make a difference. The problem is in your 10 to 15-year-olds that are playing baseball now every day instead of playing basketball, baseball, football, where they get, first of all, they get a break from those specific muscles and those specific activities. And more important, they're also strengthening, muscles that do different things to keep them more in balance. So I'm a big believer in sport generalization, not specialization, for as long as possible. It's not the trend we're going, but I think at some point it may be.
Yeah, no, I love that you said that. It's really interesting you mentioned that. It's funny. I was listening to actually, I guess, the sports podcast the other day, and they were actually talking about that, about how, the rash of arm injuries and pitchers already this season, and it's, we barely started. And just how that's happening despite the fact that obviously we're throwing less innings, like the sort of endangered species of the the classic ace that throws 7+ consistently and has 20 wins, that kind of thing. But and that's interesting to hear, because I think I've always hear the common logic being, well, it's because of the focus on, well, we're throwing with more velocity, higher spin rate, all these things. But really, which makes a lot more sense, it's that, right, you're putting so much more load on the arm from such a younger age, and being the fact that it seems like it's such an unnatural motion in many ways. You only have so many bolts in the chamber, so to speak, and we're using up a lot of them early. So that's it's a really interesting way to put about it. And it actually simplifies it. Doesn't necessarily mean it solves it, but it makes it nicer that you can explain it a little bit.
Yeah, it's a difficult problem. I don't know what the solution is, because everybody wants to keep up with the neighbors, but the youth sports has taken an interesting sort of path with that specialization.
Yeah, it's certainly tough, and I know it's, especially with the recruitment cycle. I know we see, and I'm sure a lot of people seeing this, or the parents of, we see a lot of very high level players in our facility, and I know that's definitely been a challenge. Has just been the need to play on a lot of teams, even knowing that it might not be the healthiest thing, but just, hey, if you want to get recruited and go to the place you want to go, it's just the way the system's set up. So it's it may be a problem. It may be a bigger problem than we're able to solve here. But but I'm curious too. I guess the final question I have for you, it's being the fact that you're on the cutting edge of so many things with rehab for the shoulder, for the elbow, things. I mean, sorry, surgery for the shoulder and the elbow and things like that. Are there any like new and exciting things happening sort of in your area of expertise that's exciting you these days?
Yeah, I mean, I think on the sort of on the middle-age rotator cuff side, we're certainly starting to see the rise of a lot of biologic augmentation to help rotator cuff healing. Because we know that part of the reason why people get rotator cuff tears is because there's a lot of natural degeneration of that rotator cuff as you get older, and so it makes it hard for that tissue to. And by older, I don't mean 80, I mean 50. And so it's tough to get that tissue to heal. That's part of why it takes so long to recover from rotator cuff surgery. And so there's a lot of work going on to try and figure out how to enhance that biologic process, which is, I think, going to pay great dividends in the end, where it's sort of we're like in the awkward teenage years right now. So, you see a lot of PRP and stem cells and adipose fat tissue and everything else. None of those have actually been proven to work to this point. And there's definitely stuff in there that's helpful for healing, but there's probably stuff in there that's also harmful for healing. And even the stuff that's helpful, the body is an incredibly complex thing. And so if you don't get those, even if you don't get the pattern of those signaling molecules in the right order, sometimes they can do more harm than good. And so I think 20 years from now, it's going to be a much more directed and really cool conversation. Right now, it's sort of like hitting a thumbtack with a sledgehammer. And so, I think that's an area where we're going to see a lot of change in the next 20 years. And then on the sort of the other end of the spectrum of what I do in terms of the shoulder replacements, we're really seeing a lot of move towards custom prosthesis. So, instead of now we have a lot of shapes and sizes and everything else we can use, but instead of having 12 or 15 possibilities and matching the best fit to the patient, I think we're going to do a lot of custom made implants. We use those now in the extreme cases, but I think it's going to sort of be common for everybody. You'll come in, you'll get a scan, the implant will be made to fit exactly your bone, and then we'll just kind of put it in there.
That's really cool. I did not know about that. And that's awesome, especially for, to hear as, that solutions are available to us as we age. If, you're somebody like me and you certainly beat up your shoulders, playing sports in college and stuff like that, that's good to know. And that's awesome. I really appreciate that, Dr. Wiesel. And by the way, for anybody watching this today, I'm going to put the link to find Dr. Wiesel. His website is where he's at below the video. So make sure you go ahead and take a look. And again, we've sent several of our patients at Cohen Health and Performance to him. They've had great results, great experiences. Some of them, or a lot of them, Dr. Wiesel, you said not even to have surgery. So I don't want anybody to think that necessarily that's going to automatically be the solution. Again, I really appreciate your time, Dr. Wiesel. And is there any way that you prefer people to reach you besides the website, or is that usually the best way for you?
No, I think that's the best way. I mean, on that website, there's a phone number that they can go directly to my assistant, and she can always, we can always accommodate people pretty quickly, if you need to get in. And I see patients both at Georgetown, and then I have an office in Chevy Chase, as well as one over in McLean. So try and meet everybody where they need to, let them avoid the traffic.
You got it. I know our McLean folks, especially, will be excited to hear that. That'll be nice to see. And then Dr. Wiesel, thank you again for your time here today. Really appreciate you coming on here.
Thanks. Well, thank you for the invitation, and I appreciate having you guys in the area, because I think we certainly had a need for y'all fill a niche that as you sort of mentioned before, there's the youth side of things, but then especially in that real highly active, highly compulsive middle-aged population that we see a lot around here. Folks that want to be as active at 60 as they were at 20, or more active at 60 than they were at 20, and you guys do a great job with them.
Oh, well, I appreciate that. That means a lot coming from you. And, it's all about this. It's all about the collaboration and working together. So that's awesome. And we'll excited to keep this train rolling.
Sounds great. Well, thanks for having me.
Thank you.